Hello, everyone, and welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Abdulrahman Aldahash, and I'm joined by Detective Amro Badra. And today, we're diving into a mystery hidden in plain sight, a crime scene within the body. The victim? Tiny, red, and silent. That's right, red blood cells. Something is killing them, and it's our job to figure out who, how, and why. Grab your magnifying glasses, because in this episode, we follow the trail of clues left behind by the elusive, infamous hemolytic anemias. By the end, you'll be able to crack the case like a true detective.
I usually tune out medical podcasts and listen to true crime ones instead, like Case File. Any chance this one involves a body in a dark alley?
You betcha. This episode really will be right up your alley. We're investigating cold-blooded murder. Who was the perpetrator? How did they die? And what was the motive? With that said, let's dive into it. Very briefly, can we get an overview of hemolytic anemias? Something like a mental map or crime scene, if you will, of what we're covering.
So when we say hemolytic anemias, that basically means the red blood cells are being destroyed faster than they're being made, quitting the job long before their 120-day contract ends.
So something like early retirement?
More like victims of foul play. Normally, RBCs live 120 days, but in these cases, some don't even make it to a week. Okay. To make sense of everything, think of two big categories: intrinsic versus extrinsic causes. Intrinsic means the RBC itself is defective, like Hereditary Spherocytosis or G6PD Deficiency, while extrinsic means the RBCs are normal and innocent, but something external attacks them, like antibodies in autoimmune hemolysis, or mechanical destruction in thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, or complement activation in paroxysmal nocturnal hemoglobinuria. Think of it as an inside job versus an outside hit.
Riveting stuff. So, depending on where and why the red cells are being destroyed, hemolytic anemias fall into two main categories: intrinsic or intracorpuscular. Intra, meaning inside, and corpus, the Latin word for body, which translates to within the body. And these intrinsic anemias are usually inherited shortcomings of the RBC itself, such as a membrane defect in the case of hereditary spherocytosis, or an enzyme defect like G6PD deficiency. And the second category, extrinsic or extracorpuscular, which are usually acquired anemias. Here, the RBCs are normal, but something outside is attacking or damaging them, like antibodies, toxins, or mechanical stress.
And under the extrinsic group, we'll talk about, firstly, autoimmune hemolytic anemia, which is antibody mediated, divided into warm and cold types. Then we'll talk about thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, which are microangiopathic processes where RBCs are mechanically shredded as they pass through tiny, partially blocked vessels. And finally, paroxysmal nocturnal hemoglobinuria, an acquired defect that makes RBCs overly sensitive to complement, leading to intravascular destruction. And depending on where the killing happens, it can be intravascular, inside the vessels, or extravascular, inside the spleen or liver.
Wonderful. Now, to establish some ground rules, normally old or senescent RBCs retire peacefully in the spleen and liver. They get quietly and cleanly cleared by macrophages in the reticuloendothelial system, which includes the liver, spleen, and bone marrow. There, heme is split into iron and protoporphyrin, which will go to the liver and get converted to bilirubin. Bilirubin is then combined with glucuronic acid, giving rise to conjugated bilirubin. Then, it will be metabolized and be excreted in the form of stercobilin in the feces or urobilin by way of urine.
But in hemolytic anemia, that cleanup crew goes into overdrive. Too many cells die too soon. The system floods. So you see signs of destruction.
Which explains the key lab findings of high indirect bilirubin, which results in jaundice, high LDH cholesterol, and low or even absent haptoglobin.
Right. Because haptoglobin is a protein in plasma that normally binds free hemoglobin. So now, with all the hemolysis and free hemoglobin that's being released, haptoglobin binds to it and bound haptoglobin can't be detected in labs. So haptoglobin is important. Don't forget that.
Crystal clear. Low haptoglobin equals hemolysis. Perfect.
And you'll also see signs of production, like increased reticulocytes or reticulocytosis, and nucleated RBCs, as the marrow tries to keep up or compensate by increasing the production of RBCs.
So here we have two genres of clues, signs of destruction and signs of production. With that solid foundation, let's dive into the specific diseases. Our first suspect, a shocking case of familial homicide, hereditary spherocytosis.
The classic membrane defect. Here, the crime originates in the red cell itself.
Exactly. The cause is intrinsic and inherited. It is an inherent defect in the actual RBC membrane, and it's also an extravascular hemolytic anemia, meaning RBCs are lysed outside the vasculature and inside other internal organs. More on that in a second.
Okay, now it's usually autosomal dominant, caused by mutations in proteins that keep the RBC membrane stable, like spectrin, ankyrin, band3, or protein 4.2. And because of these defects, the RBC membrane loses flexibility. Normally, RBCs are biconcave, like a donut, but without a hole, and are elastic. So this is important because RBCs constantly need to deform and squeeze through teeny tiny splenic capillaries, mainly by the help of the cytoskeleton proteins we just mentioned, spectrin, ankyrin, band3, and protein 4.2. But in hereditary spherocytosis, they lose this flexibility and become small and round, now called spherocytes.
Okay. I follow. So, detective, you're telling me that they have mutations that lead to defective spectrin, ankyrin, band 3, and band 4.2, which leads to a shortened red cell survival of 10 to 20 days. And the deficiency of these priceless membrane proteins reduces the stability of the lipid bilayer, leading to loss or shedding of membrane fragments as the red cells age in circulation.
Exactly right, partner. And these spherocytes cannot squeeze through the splenic sinusoids. They can't deform or bend like normal RBCs. So they become trapped and phagocytosed by splenic macrophages. That is extravascular hemolysis.
Riveting stuff. Now, word on the street is patients present with the all too familiar classic triad of anemia, jaundice, and splenomegaly.
Yes, anemia is self explanatory. The RBC breakdown causes a drop in hemoglobin, and jaundice because of the increase in the indirect bilirubin, and splenomegaly because the hemolysis is occurring in the spleen. Some patients also get pigmented gallstones due to the increased bilirubin. And in lab tests, hemoglobin is low, and the MCHC is increased because the cells lose membrane, but not hemoglobin, so they become denser. And you see spherocytes on the blood smear, small, round cells with no central pallor.
Whoa, now, detective. Hold your horses. Just so I follow, and tell me if I have this right, mean corpuscular hemoglobin concentration, or MCHC, is the concentration of hemoglobin in one RBC, or, for the mathematically inclined, hemoglobin divided by RBC mass. Is that correct?
Right on, partner.
All right. So if you lose bits of RBC membrane because of defects in structural proteins such as spectrin, ankyrin, and band 3, this leads to loss of RBC membrane surface area. The membrane becomes smaller, but the amount of hemoglobin inside doesn't change immediately. Thus, more hemoglobin is present within a smaller red blood cell, meaning more hemoglobin concentration per RBC, and that is why MCHC rises.
Yeah, so total blood hemoglobin is low because you're losing RBCs via hemolysis. But each individual RBC has the same or slightly more hemoglobin per unit volume because the membrane shrinks. In other words, each surviving RBC is smaller and denser, but you have fewer total RBCs. That's why MCHC increases while total hemoglobin decreases.
And for labs besides low hemoglobin and high MCHC, which, if I recall, was anything above 36, you'll see also spherocytes on the blood film and reticulocytosis, meaning reticulocytes making up 5 to 20% of the total circulating RBCs, which is also high because normally they're only 2% of RBCs. I won't lie to you, son. This is grim stuff. Let's get to the detective work. How do we actually diagnose hereditary spherocytosis?
The osmotic fragility test. Spherocytes lyse easily in hypotonic saline. Another test is flow cytometry for EMA, special fluorescent dye that binds to band 3 of the RBC membrane and measures its amount. So in hereditary spherocytosis, do you think it would glow brighter or less?
I'd wager less.
Less, of course, because less band 3. And finally, you can do DAT, direct antiglobulin test. Would it be negative or positive?
Well, from my knowledge, a direct antiglobulin test is a test that detects any antibodies or complement on the RBC surface. And in hereditary spherocytosis, the problem is not immune mediated at all. This isn't an outside actor, unlike autoimmune hemolytic anemia, for example. Here, the RBCs are destroyed because of a mechanical/membrane structural defect. So, by my reasoning, the DAT result should be negative.
Exactly. Negative direct antiglobulin test. Because there are no antibodies on the RBCs in hereditary spherocytosis. Now, for treatment, it's splenectomy, if it's severe, because it helps you remove the site of destruction, though the spherocytes themselves persist. And because of increased hematopoiesis causing stress, they likely become folic acid deficient. That's why we have to supplement the patient with folic acid.
Okay, so the management of this nasty anemia is a splenectomy if severe, since this removes the site of destruction, and folic acid supplementation is given to support increased erythropoiesis. Well, okay, since we've brought up hereditary spherocytosis, I once received word from an associate of mine of a similar criminal. Have you ever heard of hereditary elliptocytosis, detective? Word is they're related.
Ah, yes, the cousin with the elliptical drama. Still a red cell membrane disorder, but instead of becoming round like spherocytes, these RBCs stretch out and become elliptical, kind of like cigars.
And again, the defect here is in the membrane skeleton.
Exactly. Most commonly, in spectrin itself. Either defective alpha spectrin, beta spectrin, or sometimes defects in protein 4.1. These are the proteins that keep the RBC stable and flexible. When they're defective, the RBC can't bounce back to its normal shape after passing through microvasculature. So over time, it becomes more and more elongated, hence the elliptocytes.
Clinically, it's usually much milder than hereditary spherocytosis, right?
Yup, about 90% of cases are asymptomatic. Patients don't even know they have it. But in more severe cases, especially the ones with very abnormal spectrum formation, you can get hemolysis, jaundice, and anemia.
And for labs, I assume you'd see elliptocytes on the peripheral smear, long oval RBCs, yeah?
That's right. The smear is actually the big giveaway. No major MCHC increase like hereditary spherocytosis. Reticulocytosis may be present if hemolysis occurs. Direct antiglobulin test will be negative, again, because it's not immune mediated.
And making the diagnosis?
Again, the main tool is the blood smear. That's really the key. You'll see lots of RBCs shaped like elongated ovals. If the smear shows that, the diagnosis is usually straightforward. We can use EMA binding test using flow cytometry as well, but it's much more sensitive for hereditary spherocytosis. In elliptocytosis, EMA may be normal or only mildly reduced, so it's not the best test here. Also, osmotic fragility may be normal or only slightly increased, since these cells don't have the same membrane loss problem that spherocytes do, so it's less helpful. And finally, also some specialized tests exist, like spectrin quantification or advanced membrane stability assays. But those are used in research centers, not routine clinical practice.
Fantastic. So the bottom line here is, if the smear shows predominantly elliptocytes and the clinical picture fits, you've nailed the diagnosis. And for treatment, generally none is needed unless there's significant hemolysis. Most patients live totally normal lives.
Exactly. For severe cases, splenectomy can help. Same logic as hereditary spherocytosis, but the majority of patients live their whole life without issues.
So, as a recap, hereditary elliptocytosis is an autosomal dominant membrane defect in spectrin or protein 4.1. The cell membrane loses stability, giving those oval, elongated shapes that fragment under stress. Okay, now that we've handled the membrane defect family, spherocytes and elliptocytes, we can move on to our next suspect in the hemolytic anemia investigation. Our next murder mystery, G6PD.
Personally, all I can hear in my head when you say G6PD is fava beans.
Ah, yes. One of the most common culprits. You're not far off the mark. It's an X-linked enzyme defect, so mostly males will present symptomatically, while females are usually carriers. But let's start by describing what the G6PD enzyme even is.
The role of G6PD is to prevent oxidant damage. Glucose 6-phosphate dehydrogenase is crucial in the pentose phosphate pathway, producing NADPH. NADPH is important to reduce glutathione, and reduced glutathione is the bodyguard that prevents oxidative damage.
Yes, I remember this. We need reduced glutathione.
So without enough G6PD, oxidants from drugs like sulfa antibiotics, antimalarials like primaquine, or even fava beans, as we mentioned, can then damage hemoglobin, which will denature into something called Heinz bodies.
Right. So if we want to understand it at a deeper level, but keep it simple for the layman like me, we can think of it this way. Low G6PD equals more peroxides, leading to more cell lysis as free radicals will attack hemoglobin bonds. So it is triggered by oxidant exposure. Heme breaks away from globin, so the globin denatures and then sticks to the red cell membrane, and you get a Heinz body.
And splenic macrophages try to bite those Heinz bodies, leaving bite cells on the smear.
Guess the spleen just really loves ketchup. You know, fava beans could taste pretty good with ketchup.
Respectfully, I completely disagree. Anyway, as for clinical findings, some patients are asymptomatic. Others have episodic hemolysis, both intravascular and extravascular. So patients may be fine until exposed to a trigger. Then, fatigue, jaundice, dark urine. The triggers are fava beans or drugs like antibiotics or aspirin. But these episodes spontaneously resolve. And if you do a CBC, what will the hemoglobin be?
Well, I presume low.
Yes, low hemoglobin. What about reticulocytes?
Well, this one's a bit tricky. Initially, it's low because in acute hemolysis, the bone marrow still hasn't had the time to react. But later on, 2 to 3 days after, you will see reticulocytosis or high reticulocyte count.
Exactly. And haptoglobin?
Haptoglobin would definitely be low.
What about LDH and bilirubin?
High. Both would be high.
Perfect. You got it. So lab findings show increased reticulocytes, increased LDH and indirect bilirubin, and decreased haptoglobin. Now this is important, guys. What about G6PD levels? Will we measure them?
I see you're trying to pull my leg here, detective. But the right answer is no and yes. Initially, we shouldn't. During a hemolytic episode, the older red blood cells with low G6PD would get destroyed first, while the younger ones, which have more of the enzyme in them, stay around. So if you get the test right then and there, it can look falsely normal or even high. That's why it's important to do the G6PD enzyme assay a couple of weeks later when the new cells have matured and you can see the true enzyme level.
Yes. Don't check G6PD levels during an acute episode. The older, enzyme poor cells are destroyed first, so results can appear falsely normal. Test again 4 to 6 weeks later.
Now, I've heard that treatment is mostly supportive. It's self-limited, so it's best to just avoid the triggers. And if we stop the inciting agent, the acute hemolytic episodes will resolve on their own. You should also give supportive care, like managing infections, giving folic acid, and giving blood transfusions when severe. Again, Once the oxidative stress stops, the crisis resolves on its own. All right, detectives, we've seen murders by defective membranes and oxidative sabotage. But this next case, it's an inside job.
Yep, the immune system itself turns against its own red cells. The bodyguard becomes the assassin. Welcome to autoimmune hemolytic anemia.
All right, detective, let's break it down. What is happening here exactly? And how do we catch the culprit in action?
Autoimmune hemolytic anemia, or IHA, where your immune system, the bodyguard that's supposed to protect you, suddenly decides the RBCs look a little too suspicious and starts destroying them instead. So what's happening here? Your immune system starts making antibodies that target antigens on your own red blood cells. These antibodies tag them for destruction, like putting a wanted sticker on every RBC. The spleen and liver macrophages then come in to do their job, but this time they're protecting you from your own cells. The way we confirm this autoimmune crime is with a direct antiglobulin test, DAT, also called the direct Coombs test. We take the patient's RBCs and mix them with special anti-human antibodies. Basically, antibodies that bind to the antibodies on your RBCs. Feels like a tongue twister, I know. So, if your red cells already have human antibodies or complement stuck to them, the added reagent binds and causes agglutination or clumping. And that's a positive Coombs test, confirming there are antibodies or complement on the RBC surface. Basically, it tells you, yep, your immune system's attacking your red cells.
Okay, so agglutination means a positive DAT. Here, the RBCs are guilty of carrying antibodies or complement on their surface.
Now, not all antibody crimes are the same. Depending on the temperature where these antibodies are most active, we classify IHA into two types, warm and cold.
Okay, so our first type, the warm autoimmune hemolytic anemia, is the most common type. Can you go into more detail, Detective Amro?
Of course. Here, the culprit antibodies are IgG, and these antibodies work best at body temperature, 37 degrees Celsius. Hence the name warm.
All right, these IgG antibodies are small, sneaky, and even capable of crossing the placenta. Once they attach to RBCs, splenic macrophages recognize the FC portion of those antibodies and start nibbling at the cell membrane.
That's why spherocytes appear. The RBCs lose bits of their membrane after every macrophage bite. Same shape we saw in hereditary spherocytosis, but now for a totally different reason. The reason here is immune, not structural.
Right on the money. So if you see spherocytes on a smear, the direct Coombs test helps you tell which story you're dealing with. Positive DAT means AIHA, negative DAT means hereditary spherocytosis.
And this is mostly extravascular hemolysis, since the spleen is where the destruction happens, not in the blood vessels. That's why you'll often find splenomegaly and jaundice.
Right, so the classic victim picture here is fatigue, pallor, jaundice, and splenomegaly. Now, let's talk about the perpetrator. What's the cause?
Half the time, it's idiopathic. The body just decides to attack itself for no clear reason.
And the rest of the time, it's secondary to autoimmune diseases like SLE, where the immune system is already overactive and producing tons of autoantibodies. One of those antibodies may accidentally target a red blood cell, leading to secondary AIHA. So here, the hemolysis is part of a broader autoimmune problem. Or lymphoproliferative disorders like CLL. In chronic lymphocytic leukemia, CLL, or other lymphoid cancers, the abnormal B cells can start making autoantibodies. These antibodies then bind to RBCs and cause their destruction. So it's not the cancer cells directly killing the RBCs, it's the autoantibodies that they produce. And finally, certain drugs like methyldopa or penicillin, which can make RBCs look foreign to the immune system.
With methyldopa, it affects how the immune system sees the RBC antigens. So the body starts making IgG antibodies against its own RBCs. But in penicillin and some other drugs like cephalosporins, the drug binds tightly to the RBC membrane, like glue. So now, each RBC has penicillin molecules stuck on its surface. The immune system sees this drug RBC combo as something foreign and makes antibodies, usually IgG, against the drug. So all that explains the lab findings: positive DAT, high MCHC, high reticulocytes, high LDH and indirect bilirubin, low haptoglobin, and of course, spherocytes.
Beautiful summary. And for treatment, our first line of defense here is steroids, like prednisone. Can you explain to the listeners their function?
Steroids essentially calm the immune system down and reduce antibody production.
Exactly. If steroids fail, we move to rituximab, an anti-CD20 drug that wipes out B cells, the antibody factories.
And if that doesn't work, we consider splenectomy. Since the spleen is both the factory making some of these antibodies, and it's also the destruction site for the coated RBCs.
One important detail, though, splenectomy helps in warm AIHA, not in cold AIHA, since cold hemolysis happens mostly in the liver and blood vessels.
Yes, good point. Oh, and if a patient has both warm AIHA and immune thrombocytopenia, so both RBCs and platelets are attacked, that's called Evans syndrome.
Whoa, double homicide. Now, for a colder case, literally, when the temperature drops, this type of anemia strikes.
So this one involves IgM antibodies, which bind best below 30 degrees Celsius, meaning in your body's cooler parts like fingers, toes, and nose.
Chilling. The IgM antibodies form pentamers, meaning big, clunky molecules that love to activate complement. What a menace.
So in cold conditions, they attach to RBCs and trigger complement-mediated destruction. Remember, the C in cold is also C for complement, and the hemolysis can be both intravascular, where there is direct RBC lysis, and it can also be extravascular, when complement-coated cells are cleared by macrophages.
Bingo. And patients often describe things like, my fingers turn pale and numb when I'm cold. That's called acrocyanosis.
Yeah, it's tricky because it sounds like Raynaud's, but this is from hemolysis. What about the causes?
Well, from what I heard, the culprits or causes are divided into two. If the antibodies are monoclonal, think of a lymphoma. However, if it's polyclonal, think of infections, especially Mycoplasma pneumoniae and Epstein-Barr virus.
So if someone has a recent mycoplasma infection and presents with anemia and is DAT positive for C3, that points to
Cold AIHA.
mm-hmm.
And the labs show anemia with mild reticulocytosis. And on the peripheral smear, you may see spherocytes. Sometimes, the smear may even show visible red cell agglutination.
For treatment, keep the patient warm, literally. Treat the underlying cause. Steroids rarely work here, but rituximab can help.
And again, remember, splenectomy does not help here because the destruction is not occurring in the spleen. It's mainly in the liver or bloodstream. So, let's sum up this chapter of our investigation. In warm autoimmune hemolytic anemia by IgG, the spleen is the assassin, striking at body temperature. But in cold AIHA by IgM, it activates complement, and complement is the hitman, ambushing RBCs in the cold.
And both murders leave the same trace: anemia, jaundice, and spherocytes. But their motives and methods differ.
The evidence speaks for itself, detectives, but the case isn't cracked yet. Our next scene gets quite messy. Up until now, every murder had a pattern: genetic sabotage, oxidative ambush, or an immune betrayal. But this next one, absolute chaos. No clear killer, just blood in the streets, fragments of cells everywhere.
So we're talking about when RBCs aren't poisoned or targeted. They're just shredded?
Scary stuff. Picture the red cells driving through microscopic capillaries, delivering oxygen like emergency ambulances. only to find the roads blocked and barricaded with platelet fibrin clots. They try to squeeze through the gaps and get sliced apart.
And that's our clue. You'll see what's called schistocytes on the blood smear, ragged fragments of RBCs, like shattered glass at the crime scene.
Beautifully put. This family of crimes is called microangiopathic hemolytic anemia, and two notorious perpetrators run the operation: TTP and HUS. They look similar at first glance, but the motive and weapon differ. Let's start with case number 1, TTP, or thrombotic thrombocytopenic purpura. The story here begins with an enzyme called ADAMTS13, the enzyme that normally trims large von Willebrand factor, VWF, multimers so that they don't cause random platelet clumps.
So if ADAMTS13 goes missing, those giant VWF chains stay uncut and long, and they start grabbing at platelets like magnets, forming clots in tiny blood vessels. And these clots are what attack or disrupt the innocent RBCs passing by.
Wait, I have a pun for this.
Go on.
What did the RBC say after she worked hard day and night? I put my blood into this. Get it? Because it sounds like Adam ts. No? Okay. I think I've bothered you quite a clot today. Okay, guys. You don't have to make it that awkward.
Moving on, before Abdulrahman gets any more bright ideas, with TTP, it's either an autoantibody against ADAMTS13 or rarely a genetic deficiency of ADAMTS13.
And as a result, you get platelet-rich microthrombi scattered across organs, especially in the brain and kidneys.
Again, those clots slice RBCs passing by, causing microangiopathic hemolysis and schistocytes. And of course, platelets get consumed, so we get thrombocytopenia.
Now, the classic presentation is a pentad of 1, microangiopathic hemolytic anemia, 2, thrombocytopenia, 3, neurological symptoms like confusions and seizure, 4, renal dysfunction, and 5, fever caused by the systemic inflammation.
And labs show increased LDH, increased indirect bilirubin, decreased haptoglobin, but this is important, guys. Normal PT and PTT, because coagulation factors are not the issue here.
Right. This isn't like DIC or disseminated intravascular coagulopathy, where they would be high. And the key clue here is the neurologic involvement. The brain is usually the most critically affected organ presenting symptoms at first.
Yeah. Remember kidneys and brain. In TTP, that's high yield. Also, the treatment must be urgent. Otherwise, the patient can die within days.
Correct. The life-saving move is plasma exchange or plasmapheresis. It removes the autoantibodies and replaces functional ADAMTS13. You can also add corticosteroids like prednisone or methylprednisolone to suppress antibody production, and sometimes rituximab or caplacizumab to block VWF platelet binding. And remember, never give platelets. That's like adding gas to the fire. Now let's meet TTP's co-conspirator, HUS. The name gives it away. Hemolytic uremic syndrome. Kidneys enter center stage.
So here, the endothelial lining itself is injured, usually after infection with Shiga toxin producing E. coli, or O157H7.
Exactly. Here's what happens step by step. First, you get the infection with the enterohemorrhagic E. coli, or EHEC. This causes mucosal inflammation, which makes it easier for bacterial toxins, i.e. Shiga toxin, to enter into the systemic circulation. Once the toxins have broken in, they cause damage to the endothelial cells, predominantly in the kidneys. These damaged endothelial cells secrete cytokines that lead to vasoconstriction and platelet microthrombi, which will occlude the small blood vessels. And as a result of this occlusion, you get the hemolysis and schistocytes, and even end organ ischemia, especially in the kidneys, where we see low GFR.
Yes, so when HUS, remember, endothelial damage, the toxin damages endothelial cells in the renal microvasculature. So microthrombi form and RBCs get mechanically destroyed. And clinically, the patient, most commonly a child, starts with bloody diarrhea, then within a week turns pale, anemic, and oliguric. That triad, hemolytic anemia, thrombocytopenia, and acute renal failure, just screams HUS.
Neurologic symptoms here are less dramatic than TTP, and renal failure dominates. And labs mirror TTP, so you get schistocytes, elevated bilirubin, low haptoglobin, low platelets, and elevated BUN and creatinine.
As for management, it's mainly supportive care, fluids, dialysis if needed, but no antibiotics. They are contraindicated because killing the bacteria can release even more toxin. And again, do not give platelets because they can worsen the microangiopathy.
Exactly. And something we didn't mention is that there are types of HUS not associated with Shiga toxin, sometimes called atypical HUS. It could be caused by complement attacking the endothelium, for example. And for this atypical complement-mediated form, the detective's secret weapon, in other words, the treatment, is eculizumab, which deactivates complement.
Okay, so now, if we look at TTP versus HUS, both show schistocytes and thrombocytopenia, but TTP affects the brain more, while HUS affects the kidneys more.
Well said. So, in TTP, the brain bleeds first. In HUS, the kidneys crash out first. And in both, coagulation studies like PT and PTT remain normal, unlike DIC.
So the smear gives us the evidence, the organs tell us the story, and the treatment closes the case.
Okay, partner. It's 2 a.m. and the city sleeps. But inside your bloodstream, a silent execution begins. No antibodies, no toxins, just betrayal.
Betrayal. Because the red cells are being killed by their own defense system.
Exactly. Welcome to paroxysmal nocturnal hemoglobinuria, or PNH, where the enemy isn't foreign, it's you.
Okay, so let's walk through it. What exactly goes wrong? Every red cell normally wears an armor, protective surface proteins like CD55, also known as DAF, and CD59, also called MAC inhibitory protein. These act like shields, preventing complement from punching holes in the membrane.
But in PNH, something takes that armor away.
That's right. A mutation in the PIGA gene in a hematopoietic stem cell means the cell can't make the anchor or hook that attaches those protective proteins to the cell surface. We call that the GPI anchor. So now, the red cells, and actually all blood cells from that one clone, are left unprotected in a world full of complement.
So remember, mutated PIGA gene means no GPI anchor, meaning no protection from complement. Think of the GPI anchor like a seatbelt holding the protective proteins close to the RBC. No seatbelt, no protective protein.
And complement doesn't need an excuse to attack. So when the blood becomes more acidic at night due to shallow breathing during sleep, the complement system gets even more active.
Exactly. So while you're sleeping peacefully, the complement cascade activates, forming the membrane attack complex that drills holes into the unprotected RBCs. They burst, causing intravascular hemolysis.
That explains the name. Paroxysmal, meaning sudden episodes, nocturnal, so happening at night, and hemoglobinuria, so hemoglobin in the urine.
The victims or patients often wake up with dark, cola-colored urine, filled with free hemoglobin, not intact RBCs.
But since the mutation happens in a stem cell, other bloodlines, like platelets and white blood cells, are affected too.
Exactly. And that's why PNH isn't just a hemolytic anemia, it's also a thrombophilic state. When the platelets are stripped of their protective proteins, they become hyperactive. So you get thrombosis in unusual sites, hepatic, portal, or cerebral veins. Think of Budd-Chiari syndrome, which is hepatic vein thrombosis.
So the lab pattern fits intravascular hemolysis. Increased LDH, increased indirect bilirubin, decreased haptoglobin, increased reticulocytes, and of course, hemoglobinuria.
And the confirmatory test, the flow cytometry, checks for missing CD55 and CD59 on RBCs or granulocytes, which are the protective proteins we talked about that lost their GPI seatbelt. Old tests like the HAMS or sucrose lysis are history. Now, flow cytometry is our modern test.
What about treatment?
We can use eculizumab. If you remember, I briefly mentioned it previously. It's a monoclonal antibody that blocks C5, preventing the membrane attack complex from forming.
So, eculizumab stops the destruction mid-attack.
Exactly. We can also use ravulizumab, a longer-acting version, and, of course, iron and folate supplementation for the anemia. So, detectives, before we close the case file, let's line up the culprits one last time.
First up, hereditary spherocytosis, a structural defect in RBC membrane proteins like spectrin and ankyrin. The cells lose flexibility, become spherocytes, and get trapped in the spleen. You get extravascular hemolysis. Treatment, splenectomy, and folate.
Then came G6PD deficiency. A missing enzyme, G6PD, leaves red blood cells defenseless against stress. Triggers include drugs, infections, and fava beans. As a result, you see Heinz bodies, bite cells, and episodic hemolysis that resolves when the insult ends.
Next, there's autoimmune hemolytic anemia, the attack from inside the house. Warm IgG antibodies strike at body temperature, and the spleen takes out the coated cells. Cold IgM antibodies strike in cold zones, and complement attacks intravascularly. Remember, C cold and C complement. Treat warm IHA with steroids, rituximab, maybe splenectomy. Treat cold IHA by keeping warm and targeting underlying infections or lymphoma.
Then, the crime scene turned chaotic. TTP and HUS, the microangiopathies. In TTP, ADAM-TS13 goes missing, causing widespread microthrombi and neurologic chaos. In HUS, Shiga toxin or complement injury destroy the kidney's vessels. Both leave a trail of schistocytes.
And finally, PNH, a stem cell mutation that removes RBC protection, letting complement destroy cells by night and trigger clots by day. Treated with eculizumab, a modern shield against the body's own betrayal.
So remember, detectives, before we go, every hemolytic anemia leaves behind a trail of high indirect bilirubin, high LDH, low haptoglobin, and high reticulocytes. Follow those clues, look at the smear, and you'll always find the culprit.
Whether it's a membrane defect, an enzyme failure, an autoimmune assault, mechanical trauma, or complement's revenge, there's always a story in the blood. And as with any mystery, the key is to read the clues carefully, because sometimes the killer hides in plain sight.
Case closed. Stay curious, detectives. Until next time on PodBites. اسمع، نطمر النكتة السامجة هذه إن كفاية كرنج اليوم يعني.
اوكي.
لا ليش لا مو لازم، والله مو لازم، والله مو لازم، والله مو لازم، والله.
يا اخي ما حد يشوف الفيديو والله خلاص.
يا أخي هذه كاتبها شات جي بي تي تكفى.
ترى حلو والله حلو.
Wait, I have a pun.
ترى بضحك عليها امبارح.
I put my blood into والله ما أقولها.
بعديها حلوة.
تعال عمر قولها ولا أنا ما راح أقول.
تكفى. ترى والله راح حتكون
تسوقها على مين؟ يا أخي تسوق على مين تكفى، هذه يقولها لأخوي الصغير.
The body just decides to attack itself for no clear reason. The body just decides to attack itself for no The body just decides to attack itself for no clear No clear reason. No clear reason. يا عمي يلا خلاص.